Yes.
Handy dandy.
Savory meal plans.
Stand.
Gonna make pasta tonight.
Oh, what's that TikTok audio?
It's my favorite meal.
Stanley.
You never go wrong with it.
I have a question.
Yes,
So with the VNG,
yes.
because it's like our bedside but with data. In a place that has VNG equipment, would we even bother doing bedside or
You may run a restricted bedside protocol.
just to get an idea?
So when I did my vestibular protocol in clinic, I would do extraocular range of motion, cover cross cover, and head thrust. Because that gave me an opportunity to think about how the system was performing bedside and allowed me to build a hypothesis of what I expected to see on the VNG. And if I saw things that aligned with what I was seeing on the bedside assessment, I'm like, okay, my hypothesis was pretty strong. If I saw a positive right head thrust, and then I saw left beating nystagmus throughout the VNG, I'm like, this makes sense. I know that we have a high frequency concern with the horizontal canal by head thrust, and I'm seeing stuff to back it up on VNG. So I like the bedside assessment. Plus, I think it helps you get an idea of how the patient's affect is, and if they're gonna be willing to do some of the activities that you're gonna ask them to do that day. It takes no time.
Okay.
Yeah, and you can look at their eyes, right? Imagine if you don't do extraocular range of motion and their eyes aren't moving. And then on the VNG, everything's abnormal, and you're like, oh, I didn't realize that your eyes weren't conjugate. And they're like, yeah, the left one's glass. You're like, oh, okay, well, that changes a lot. That changes everything. So that's what we're gonna actually talk about today, is I'm gonna introduce you to the vestibular case history and thinking about how drawing information out of the patient is actually the most valuable thing about the vestibular assessment. I often think about our role, it's not necessarily about obtaining the test results, it's about obtaining the story at the end of the day. Because often this appointment is 2 hours long, and it's the first time that patients have an opportunity to tell their story in full, or have an opportunity to explore different facets of their story that they haven't talked about with other medical providers. Because other appointments may be 15 or 20 minutes in length, and with random case histories taken throughout, whereas in this appointment, you have the time to figure out what's actually happening with their dizziness. Does that mean every appointment is going to be 2 hours? No. I actually advocate for the fact that vestibular testing and audiology reconsider the 2 hour VNG, because it is not revenue generating. 2 hours worth of time is a significant amount of time, and the reimbursement for VNG is not very high. If you are a very skilled clinician and you have really good upfront, like front desk triage, you can listen to a patient's story, get the case history, and say, hey, I only need you to come in for a VHIT and VEMS. And that could be a 45-minute appointment. And you could see 7 or 8 of those people in a day, and then allocate some of these more aggressive, longer tests for individuals that need to come back and do that type of work. And build your schedule out so you can see more vestibular patients in a day, because the vestibular wait times are months often. It'll be like 8 weeks for an appointment, is because we have these massive 2 hour blocks. Additionally, in those massive 2 hour blocks, if you have a patient that no-shows, that's 2 hours, right? And you can't call up the next person on the vestibular wait list, one, because they've probably taken medication, which makes it difficult for them to do the test. And 2, they need to have a driver, so they have to have some planning surrounding it. And 3, they're dizzy, so probably not leaving their house that day. So with those 2 hour blocks, and when you have a high no-show rate, that becomes a real issue. You lose a lot of your revenue generating opportunities in that sense. Additionally, I think it allows us to work at a higher level of our scope of practice. An individual who's a technician just does the same thing every single time and can't make deviations. But an audiologist who is able to process information and pick the appropriate tests can work at a much higher level. So there's something for everybody. With that being said, when I was at USC, did I have all this block scheduling? No, I had 2 hour appointments. It's a culture shift, kind of, relative to that. It's also, I think, better for the patient to have smaller appointments when you think about some of the patient populations we serve that have like vestibular migraine. If you bring them in for a 2 hour appointment, they are ill within the first 15 minutes. And now you got 45 or an hour and 45 minutes left to try to get them through a test battery. And it often can trigger more intensive migraine presentation later in the week because they're just not quite ready to rock and roll. So this is in the ENG, VNG test battery. So we have electrodystagmography, videodystagmography. This is in the Caslin book. It should be available to you in the back in the library. I also have it in my office. Okay, so this is about kind of thinking about case history and the information that's important relative to obtaining a case history. And in the introduction to the vestibular case history, we're going to talk about things that you've probably spoken about relative to the auditory case history. But in this case history, we want to be mindful of the fact that we're trying to build a story about the patient's symptoms of dizziness. The auditory symptoms are important, but we need to figure out how that patient is characterizing their presentation and their internal perception. Just like with hearing loss, it's not something that we can see, but dizziness is something that can have an incredible impact on quality of life. And what you might find is your patients don't have the language to explain what they are experiencing. You will get a lot of, I'm dizzy, and you're like, okay, how does it feel? What does it look like? When is it triggered? And that helps you figure out, is this central or is this peripheral or is this both? And helps you build your hypothesis. So in the introduction to the vestibular case history, the evaluation starts in the waiting room. When you see that person sitting in the chair in the waiting room, that can give you a pretty good indication of what is going to continue to walk through the door for you, okay? Often in hospital settings, you are the one that goes to get the patient from the waiting room as the audiologist. So you'll grab them for your hearing test or you'll grab them for their V&G appointment. And having an opportunity to look at them in the waiting room is one of the best tools that you have before you even encounter the patient. Often they are asked to bring a driver, and you can't always make the assumption that that person is a friend or a colleague of that patient. So sometimes it is a family member. You always ask the patient permission to bring that person back with you, because sometimes those family members assume that they're just going to go, and that patient may not want that individual in their appointment. At the end of the day, it's the patient's appointment, not the driver's appointment. Additionally, I've had people who are driven by their neighbors, by like friends of a friend of a family member. They only know this person for this appointment. They're not interested in attending a 2-hour appointment, basically with a carpool buddy. Okay, so it is being something that you have to be thoughtful of. How is the patient sitting? When we think about how a vestibular patient may sit in the office, you might find individuals that are perfect and upright, and then you might see individuals with their eyes closed, just gazing off in the distance. If their eyes are closed, it's probably a good sign that they're not feeling well in the waiting room itself. You may see individuals that are leaned to one side. You may see individuals that are gripping onto the chair for dear life. All of those are cues that perhaps where they think they are in space is not necessarily what's actually happening in the environment. Once they get up, a good point of cue is how do they get up from the chair? Are they using their arms to push themselves up, which would suggest they don't have strength in their lower limbs, or the core strength, some decompensation in that space? Are they using a walker, a cane, or another assistive device? And how are they using it? Walkers, canes, and other assistive devices should be fit by a physical therapist. They should keep the patient upright with their line of gaze outward. What you'll find is a lot of family members inherit their assistive devices from other family members that may not be using it anymore or who have passed away. And as a result, you will see this lovely 4'9" grandma carrying a walking stick for her 6-foot husband. And you're like, that is not, it's not gonna work. It's not gonna work here. But that's what she has, and that's what she wants to use. So we have to be thoughtful about how we're using these tools. You'll also see a whole host of individuals, which would be like 2 older individuals, 2 people that are both at risk of falling, holding on to each other as their emotional support walkers, okay? So you have 2 people that a gust of wind could blow over, holding on to each other to make it into the appointment. All right, it's a good conversation to talk about both of their balance and gait function. What's the pace of their gait? I've had patients that have taken 35 minutes to walk back to our appointment. They're dizzy, they feel unwell, they do not want to move quickly. It's probably a pretty good sign that we're having some challenges with quality of life, and also gives me a pretty good indication that this patient may be incredibly difficult to test if they're not interested in moving very fast or at all. In that test battery for that patient, What we did is every like 10 feet, I would put a chair and I would have them sit down and regroup, but I would also do a bedside test. Because I recognized very early on we weren't gonna get very much information that day, just making it back to the B&G. So we kind of built in some testing as we went and worked with that person. And do they turn their head? Patients with vestibular loss do not like to turn their head. They will do anything to prevent that from happening. So if you have an office with a curve or a hallway, what you may see is when they go to take the turn, they might turn their head and then move their body. Or if they're kind of just quick movers, they turn everything and they may fall into the wall. If you have a hallway and someone feels unstable, they'll often run their hand across the hallway when they're talking to you to hold on. So all of these are nuances. You don't have to point them out to your patient, but things you can make note of to give you an idea about how they move from point A to point B. Yes?
Going specifically back to like standing up,
Yes.
if you see that they might not have the core strength, if you're gonna do something like CVEMS, are you thinking, okay, maybe we need to do a different setup from the typical supine head up?
You can consider that where you're doing a different setup, or you can think about having them sit upright and then turning their head in order to accommodate it. Some patients may not move their head because they don't have cervical function. They don't have a cervical spine to do it. So we have to be a safe cervical spine to do that type of head movement. So always asking about that. I think too, when we think about how we define a fall is unintentionally coming to rest on the ground or a lower level, okay? So while you're watching your patient get up from the waiting room, if they push themselves off and fall back into the chair, that's a fall. And when you're explaining a fall to a patient, we often give the definition. You always define it. It's unintentionally coming to rest on the ground or a lower level. And you ask them, have you ever fallen? Most of them will say, no, I don't fall. And then you can say, in the waiting room, I watched you try to get up from the chair and you fell back down into it. That's a fall. Does that happen often for you? And they're like, well, yeah, every day. You're like, okay. So you are having a hard time moving safely between point A and point B. Yes?
Is it allowed to have like a wheelchair to take people into the room?
You would think. So some places don't have a wheelchair, which we did not. So that's why it was archaically slow. Have I rolled people back in office chairs before?
That's what I was gonna ask.
Yes.
That was my next step. Okay.
One day I will tell you my nightmare dip project about the foster grandparents. We'll talk about the utilization of office chairs to roll people at risk of falling around large spaces. Is it a good look? No. It's not a good look to be like, please sit down. We don't have a wheelchair. No worries, we're a hospital setting. Trust me. So that is where, you have to be thoughtful, but then sometimes people don't want a wheelchair because they are just not interested in engaging in that. So it's a good point.
For the head movements you're talking about, I'm thinking about patients who have had an ACDF surgery. Does that impact?
Do you want to expand on what ACDF is?
Oh, anterior cervical disc fusion, or it's like C1 to C.
When we have any fusion of the discs, that can definitely impact neck movement.
Okay.
And also like vertical movement of the neck. And I always ask them how frequently, our friend is here today, or how frequently or how far they can move their head and neck, like what their doctor allows.
I'm just wondering because I think it's like one of the most common spinal surgeries.
You'll run into a lot of patients with spinal surgery like that. Is it okay for patients to wear their hearing aids during the B&G? Absolutely. They need to be able to hear the instructions that you're providing. Often it's done in the dark. Additionally, their cochlear implant can be activated. The thing is that when we're doing any type of water irrigation, air or water for caloric irrigation, we'll have them remove the hearing aid in the ear that we're testing. Additionally, if you're doing a water irrigation, make sure you dry out that ear before you put the hearing aid back in, okay? No wet hearing aids. For individuals that are visually impaired, we have to think about the fact that we're utilizing the eyes in order to look at targets and to track targets across space. In severe visual impairment, we have to ask ourselves, can we calibrate for this patient? can we get adequate calibration? Can this patient see enough for us to verify that we have a good relationship between the eye movement and the target of interest? And that's kind of our breaking point. If we can't calibrate, if the patient is unable to see the target effectively, then we need to think about the fact that we're going to use a default calibration and we cannot complete the oculomotor test results, really.
So it's not an option for them to be wearing their contacts?
Their contacts are fine.
Okay.
Contact lenses, the best corrected vision is what we are seeking. A lot of older adults don't wear contacts. They wear prescription lenses. And once you have them move the prescription lens, the actual eyeglass, that's where we run into a lot of visual difficulties. There's another assessment and evaluation called an ENG, electronystagmography. That's a word. Use that and Scrabble, okay? Electronystagmography that uses electrodes. Those electrodes are placed on the skin and around the eye, and you can wear the patient's glasses, the patient can wear their glasses over that. So it's actually really helpful when you're working with older adults. They really stopped making these. So there's a handful of sites that still have this as an option, but a large handful of sites don't. We only have the video goggles where we cannot wear the prescription lenses, i.e. glasses. Contacts, completely fine. And what you can see actually is the contact sliding around on the eyeball sometimes, which is fun. You at least know they're wearing it, right? What if the patient is blind? We can still do caloric irrigation, meaning putting air or water in the ear in order to excite or inhibit the vestibular system. Why? Because we do not need vision to do this task. And what we can do is we can measure the response. We can only make statements about vestibular function that are vague in nature, present or absent. Did the patient generate a response when I excited the right side? Did they generate a response when I excited the left side? And were those responses consistent with what I would expect for a healthy vestibular system? We don't want to make calculations about asymmetry between the sides or weakness between the sides, because hypothetically we're not necessarily dealing with a system that's typically functioning relative to the visual system. Additionally, we can have nystagmus that is generated because the patient is blind, where with the lack of visual acuity, the eyes will drift. And it's not nystagmus that is related to vestibular loss. It is nystagmus that is related to the fact that we don't have clear visual acuity. Patient populations that you may encounter relative to blindness would be ushers, where we have had a loss of visual function, and we need to verify the vestibular status, especially when we think about the relationship of the balance system, our visual system, our somatosensory system, and our vestibular system working together. If we have a loss of visual and vestibular function, we're solely relying on what we can sense in our feet and ankles and our core to keep us upright and safe. So for majority of cases for ushers and vestibular loss is uncommon, but it doesn't mean we can't have other things going on. Doesn't mean that you're not going to get an upper respiratory infection and lose your vestibular system. Some crazy things happen, even though you already have one diagnosis at the end of the day. So, something to think about. Okay.
I have a question.
Yes.
About the unilateral directional dominance. Can you explain that more? Why
Yes.
we can't?
So with this, unilateral weakness or directional preponderance, these are two calculations derived from the caloric. Unilateral weakness tells us which side is weaker, right versus left. Directional preponderance tells us which nystagmus was stronger, right beating nystagmus or left beating nystagmus. Due to the fact that we don't have an opportunity to provide fixation or a point of interest for the patients to look at during the caloric, and the fact that we are operating with an ocular motor system that is atypical in some way, it would be inappropriate for us to say that one side is stronger than the other because we don't necessarily know the underlying ocular motor system. We can say, okay, when I put warm water in the right ear, I saw right beating nystagmus, which is good. When I put warm water in the left ear, I saw left beating nystagmus, which is good. The system, the vestibular system, is responding to the stimuli. I'm not gonna say the left side was stronger than the right, because the underlying visual system may have some differences that would change that. Annalise.
So for directional preponderance, and like someone who we can test who doesn't have those visual deficits,
Yes.
are we only using that term in cases where we're observing that bilateral nystagmus?
So directional preponderance in caloric irrigation, you're gonna see nystagmus in both directions, the right and left side, in both ears. Cold water actually causes the eyes to move opposite of the irrigation, and warm water causes the eyes to move in the same direction as the irrigation. The acronym is COWS. Warm opposite, cold same. No, cold opposite, warm same. I almost got a tattoo that said that. Okay. Could you imagine if I messed it up? I have a PhD in vestibular.
You're like
Joke's on
looking
you.
at your arm during the test.
I'm like,
What
look
did
at
I
my
say?
mentor. Just like, what happened? Like, take it off. Be like taught by Julie Honecker. She'd be like, oh my gosh. Cold opposite, warm same. The acronym is COWS. Okay. So when we think about this, we are expecting in a healthy system to see this pattern. It is when we don't generate a response, the response is weaker, that we start to worry about a unilateral weakness, one side not being as responsive as the other, as well as when we see nystagmus that's always stronger to the right. That directional preponderance tells us something about how the system is generating the nystagmus direction.
Was the directional preponderance telling us which is the stronger neural side?
The unilateral weakness is telling us the stronger neural side. The directional preponderance is telling us the nystagmus direction that is stronger. So am I seeing more right beating nystagmus or more left beating nystagmus?
So if it's more right beating, that's the stronger neural side.
If it's more right beating, what that tells me is that when I put warm water in the right ear and cold water in the left ear, that the strength of the eye movements is greater than if I was to put warm water in the left ear and cold water in the right ear.
Those are statements we can only make when there's no visual impairment.
No visual impairment.
I'll understand that someday.
That is at the end of this unit, so we'll get there. I just wanted to let you know you could do calorics on a person who was visually impaired. We went on a bird walk, it's fine, we learned a lot. And I learned that I got my acronym backed up this year. Question?
Kind of off topic, but so can you do OVEPs on someone that's blind if you don't know the system, their eye system?
The difficulty with that I could see is how do you direct their gaze? Because you need the gaze lifted upwards. So if you have limited visual acuity and you're giving them a point of interest that you know is controlled, but they can't, it's hard for you to get their eyes to that point of interest, I would probably forgo that and I would focus on the CVEM. Okay. Now that we're thoroughly confused, we're going to talk about the questions that we ask these patients. So the vestibular case history is the most important part of the vestibular assessment. Out of the 2 hours, I will tell you I spent 2 hours on case history. It sounds weird, but I am talking to you the entire time. Because guess what? This isn't a hearing test. This is a vestibular test. And I have you in that chair, trapped with me for 2 hours. So we're gonna get to the bottom of what's going on here, all right? With that in mind, it helps you generate a hypothesis that you can look at from your objective tests. So does this hypothesis align with other neuroimaging or electroneurodiagnostic tests that this patient may go through? And this hypothesis that we're generating from the case history is the patient's experience. What happened to cause their dizziness? What can they pinpoint that makes their dizziness worse? How does their dizziness feel? Is it dizziness or is it vertigo? Or is it imbalance? Or is it a combination of all three? You're trying to break down the buffet that they bring you relative to their symptom presentation. Because different presentations can mean different things at the end of the day. There's a lot of work relative to AI in having patients fill out intake forms regarding dizziness to direct them to the right care path. Because dizziness is expensive to manage. It can come from neurology as a neurologic issue. It can come from cardiology. It can be something that's orthopedic in nature. It can be something that's related to the vestibular system and ENT. And often patients will visit 4 providers before they make it to a V&G. So they've already utilized all that healthcare, probably had imaging, probably have been to the emergency room, and we're just now getting to the point where we can figure out what their vestibular system is up to. So the hope is that we can better move these patients through the system by asking the right questions at the end of the day. So the challenges of the vestibular case history is sometimes the information that we get is of limited value to differential diagnosis, all right? Like my patient who only experienced dizziness with Billie Eilish. There was a period of time where that did not seem like it was of much value to me. I've had other patients describe their symptoms of dizziness. I will remember this person because it was very early on in my career. You asked her how she felt. She said, I feel like I'm walking on a cotton candy cloud. And I said, okay.
That sounds nice.
That sounds, yeah. I was like, so you feel unstable? She said, no, I feel quite fine. I just feel like I'm just floating. Floating above myself. And I was like, okay. And so then in the report, you're like, patient feels as if she's walking on cotton candy cloud. V&G normal.
Quotation marks.
Quotation marks, yeah, direct quote. Patients often feel like they're being ignored. And this can come from the fact that they've come from multiple providers and they don't feel like they have been listened to at any of these sites. So sometimes you have patients that come in that are going to be incredible advocates for themselves who really want you to listen this time. And you have to make space for that to happen because they may be coming in from some other challenging medical experiences where their concern has not been validated. And in a lot of cases, the vestibular results will be within normal limits. So how do you make sure that you're still acknowledging this patient's experience, but addressing the fact that when we put in the vestibular piece of the puzzle today, we note that it is working the way that it should. That means we can direct our attention to these other areas. We need to spend more time in these other spaces looking for you. There could be an insufficient amount of time. Sometimes the stories are too in-depth. There's too much going on, it feels like. But if you ask the right questions, you can get the answers you need to fill in your piece of the puzzle. And that's what's important at the end of the day. Vestibular patients are known to be incredibly emotional. And this is one of the reasons people do not like vestibular work. That the patient experience is too strong when that patient is in this space with you. Often patients are coming in with a wide variety of previous medical experiences. There can be trauma related to their symptoms of dizziness. Often people have had incredible changes in their quality of life relative to their symptoms of dizziness. And there are some strong emotions that can come into that space. So how do you manage the emotion? How do you manage the expectation? And how do you get through the appointment so everybody gets what they need at the end of the day? I will say that I had patients cry every single day, and it's just a part of the test. It's not because you're doing the test battery, it's because this experience has been so challenging for them. So being able to hold space for that person, allow them to release their emotions, and then set realistic expectations about what you're going to do that day. Because they have maybe been told by someone else that you're going to solve it. I regret to inform you, probably not. Because there may be other things going on that are beyond the scope of practice of audiology to help that patient out with. Additionally, with emotional variability, we can encounter patients that it's not necessarily emotional, but can be experiencing mental health challenges. So a significant amount of anxiety and depression in this population. So making sure that you're well aware of the protocols within your hospital for individuals that are expressing thoughts of life-ending intervention and verbalize that to you. And how do you manage those types of conversations, and who is the next step in the chain of command in the hospital to help you verify what you need to do for that patient? Yes?
That's something I thought about in previous classes as well, whenever we would have patients who we see, for example, bruises on, or patients who express, these type of thoughts.
Suicidal ideation.
Do we report these things to
Are we
anyone?
mandated reporters?
So within,
Sorry.
you bring up a really good point. So in the state of California, you are a mandated reporter, okay? So be mindful of that. That includes obviously the whole scope and spectrum of what that means to be a mandated reporter. So if you are noticing that perhaps you're seeing signs of child abuse, you're a mandated reporter. If you are seeing signs or concerns of elder abuse, which can include financial abuse, you are a mandatory reporter, okay? If you are in a position where you ever feel like something is not quite right, know that you have resources most likely within your hospital and as a provider to help you figure out what to do next. I have in dizziness in particular, in some subsets of individuals where you are working through maybe a cochlear implant evaluation, where they have been socially isolated because of their hearing loss for an extended period of time, and then the intervention isn't working. In individuals obviously with tinnitus and with dizziness, depression, anxiety, and untreated depression and anxiety are not uncommon. And you will also have patients express, especially if they have reached their end, suicidal ideation. And what is your next step as a provider relative to that? And your hospital should have guidelines. And I always made sure to let the hospital know. Even when I was at Nebraska, we didn't have a hospital, but I would call the physician immediately and let them know, this is what the patient said to me, this is how they expressed it, this person needs help.
I did a lot of, when I was in the hospital setting, there's social workers, I did a lot of referrals to them, like after I saw a patient for an eval. So becoming, at least in my experience,
Yes.
becoming friends with the social workers, the staff there, they're helpful.
Social work is an incredible resource because also in your case history, you may discover housing insecurity, food insecurity, and multiple unsafe situations, which could exacerbate and increase the symptoms of dizziness. Because anxiety can increase the symptom. Depression can increase the symptom. So if we're not managing these underlying mental health concerns or like environmental concerns, we are gonna have a really hard time getting better at the end of the day. So, plugging in the pieces of the puzzle. All right?
I have a question.
Yes.
The last slide, when you said a lot of the time, the vestibular results can end up being within normal limits, is there, so then what else is going on or causing this, or do you see that there's, I actually don't know how to word my question.
So sometimes what can happen is the symptoms of dizziness, the way that they're described, can be broad and vague in nature. And as a result, it opens up a whole host of things. There's a subset of dizziness that's thought to be brought on by anxiety, untreated anxiety. And as a result, we're feeling this woozy, lightheaded sensation that is irrepressible, that is not being driven by our vestibular system. And the first thing you don't want to say to the patient is, well, it's because I think you're anxious, and that's why this is happening, right? So we acknowledge that the symptoms and feelings of anxiety can exacerbate or make our symptoms of dizziness worse. And as a result, we need more tools in our toolbox to help you manage those symptoms, manage those feelings, and give you an opportunity to have the strategies to encounter the challenges that you're having on a daily basis. Because you may know some patients say, well, when I feel anxious, my symptoms are worse. You're like, well, that would make sense. It's feeding into that loop in an unfortunate way. Other symptoms may be autoimmune in nature, where we have autoimmune issues that are driving exacerbated symptoms of dizziness and unsteadiness. I have encountered many patients who suffer symptoms of dizziness, lightheadedness, unsteadiness after grief, where they have lost someone or where they were the caregiver of someone and that person has passed, and now they're navigating that space and it makes they're feeling unwell. They don't feel like themselves. Migraine type headache, very common. And in migraine, we may not see abnormal vestibular function. So there's a whole plethora of things that can present as dizziness. Sometimes it's cardiovascular. They're not dizzy, they just feel like they're gonna pass out. We are not gonna do anything about that as audiologists, but we need to get your blood pressure checked. How long have you been taking your blood pressure medication? Was there a change in your blood pressure medication? Have you ever lost consciousness? I've had patients where it's seizures that are causing the symptoms of dizziness, that are kind of going unmasked or like hidden in a way. So it could be everything, or it could be the way that they're perceived in their world, which would be more of that anxiety, which can lead to kind of agoraphobic behavior, not wanting to leave the house. And then our quality of life is decreased. We're not working anymore. We don't have a paycheck. We're afraid we're gonna lose our home. And then the depression hits, and then it's a bad cycle.
So in these, patients, is there a case to implement some sort of like mental health screener in order to make a referral, or is that not?
So we can use the hospital anxiety and depression screener, or the HADS. That gives us an opportunity to check in on the mental status of our patient population. We can also use, is it the PQI? What is the other one? There's a handful of screeners that can be utilized, and sometimes utilized at the intake for your ENT office, to give you an idea of what patients are experiencing. The Dizziness Handicap Inventory, the DHI, also lets us check in on social and emotional concern relative to symptoms of dizziness. Sometimes patients will tell you that they have a pre-existing diagnosis of anxiety or depression, and then the next question will be, how are you managing that? Are you visiting with someone? Are you taking medication? Are you doing a combination of both? Because sometimes patients were maybe just prescribed one thing, and then they're taking it, but they don't feel like it's doing anything. And so it's something to bring back to their PCP relative to a plan of action. Yes?
Are we taking vitals at the beginning of our appointments?
So what happens at the audiology appointment is typically the vitals are not taken, but when the patient goes to visit with the ENT afterwards, the vitals are taken. It depends on the triage of how that patient is scheduled. But vitals are usually taken that day, if you're in a hospital setting. Outpatient vitals typically are not taken. We can take blood pressure measurements relative to orthostatic dizziness, orthostatic hypotension. The challenge with those is that you need a blood pressure cuff in your office, and you need to feel confident. And if you start reporting them, recognizing that it's not necessarily considered within our scope of practice. We can look at it and say, oh, this looks like you need some blood pressure help. But we wouldn't necessarily have that conversation with patients.
I have to take them every time in a home health visit.
In
I
home
have
health,
to,
yeah.
Mhm.
That is it. That's a key piece of the puzzle. We have 6 kind of questions that guide the vestibular case history that we are going to cover in 11 minutes. No, kidding. These questions can guide additional questions to fill in gaps about the patient's experience. And the first question is, can you describe the sensations that you're experiencing? So when we talk about I feel dizzy, what does that mean? What is dizziness? Can anybody describe what dizziness is?
Feeling like instability.
Instability, okay.
Spatial disorientation.
Spatial disorientation, what do you say?
The room is spinning.
The room is spinning.
Lightheadedness.
Lightheaded. So you all just described 4 different types of dizziness. Patients will often say they feel drunk. I'm drunk. You go, okay,
That's a good one.
that's it.
What if you don't know what that feels like?
Exactly. So then you have subsets of populations that are like, I just don't feel like myself. I don't feel connected. It's not uncommon in migraine for people to say, I feel like my head is floating above my body. Like my head is on a balloon. I'm above myself. If you ever have a patient say that they're out of their body, observing themselves from above, that is not dizziness. That is like disassociation. That is mental health. Yeah, that's where we need to, someone else needs to come in with the tool in the toolbox for that. If you're observing yourself from the outside, we are no longer experiencing dizziness, okay? I've had a couple patients that have, and I'm like, and what do you experience? They're like, well, I leave my body and I float above, and I'm like, okay. What do you feel when you're outside of your body, all right? Dizziness is challenging to describe in English. It's very hard to describe in other languages as well, especially if you're not a primary speaker of that language. In Spanish, dizziness has many terms, but none of them really capture the exact English translation. Mareado, I think that is dizziness, and I would get borracho a lot. They're like, a borracho, I'm like, okay, you and everybody else in here, everybody just feels drunk, right? And then at the end of the day, you'd have to think about too, how are we gonna expand on that? When do you feel that? How often? How long does it last? What triggers it? Dizziness can be challenging, but you're trying to draw out of your patient more information about that sensation. Let the patient describe the symptoms in their own words to start. You're gonna get into a subset of individuals that are incredible creative writers that'll give you every detail about their dizziness. You're gonna get other individuals that are like, I'm dizzy, I have nothing more to say to you. You're like, great, all right. The dizziness can have more than one sensation or symptom. So start describing different types of sensations. Do you feel like you're on a boat, like you're rocking? When you feel the room spinning, are you spinning around the room, or is the room spinning around you? When you feel unsteady, are you being pulled to the right or left, or pulled forward? Or do you feel weak? Trying to get more details can help you sort out some different information. Follow-up questions to ask can be in regards to time. Does it worse in the morning? Is it worse in the afternoon? Is it worse after you eat? Sometimes we are the first people to identify that the patient might have diabetes, especially if it's about an hour after they eat. They feel really out of sorts, they feel disoriented, they're feeling weak, they feel sick, they feel dizzy, they feel nauseous. Additionally, often you'll encounter patients who have had all kinds of dizziness across a period of time. Have you had anything like this in your past? How is it different than what you experienced before? Is this new? Okay, because you might have patients who have had Meniere's disease for an extended period of time, and now they're experiencing instability. Those symptoms are different. Perhaps you have a patient who's had a history of migraine, and now they have vestibular neuritis. That's a different presentation. When we're asking these questions, we're trying to pull out peripheral versus central sensations. Peripheral being that the acute, vertiginous, 24 to 48 hours type of vertigo that lasts for a short period of time that's then exacerbated by head or body movement afterwards. We're thinking about that static and dynamic compensation phase. Whereas central is vague. It is uncertain. There's no triggering event. It's just kind of an all the time disorientation or dizziness. So when we think about how patients are experiencing this, what if they can't describe the sensation? You're just trying to direct them. Bring them along with you. Are you unsteady? When did you start using your cane? What was the event that caused you to start using your cane? Have you fallen because of your dizziness? Do you feel like the sensation is in your head or in your body? Some patients say it's just in their eyes. Their eyes just feel dizzy. And you're like, okay, where do we go with that? Have you changed your prescription? Have you been to the eye doctor? When did your eyes start feeling dizzy? Do your eyes feel heavy? Do you have pressure behind your eyes? It's that type of curiosity that helps you sort out what this person is actually experiencing at the end of the day. It is like playing a detective with like 1 or 2 clues on the board, and by the end you should have more information about this mystery that this patient is coming in with. When we're defining dizziness, this document can be incredibly helpful for us. This is from the Barony Society, and I posted it for us here. The Barony Society is a society of individuals that are like the pure vestibular interest group. They meet in Uppsala, Sweden, and in Madrid, and this is the who's who of the vestibular world. And they come up with these consensus documents, which I'll share with you throughout the semester, and especially in vestibular too. But they help us describe the terms that we use. So they came together to talk about what type of language we should be using when we're describing dizziness, when we're describing vertigo, and when we're describing unsteadiness. Because just like we've talked about with patients, it's also a free-for-all with providers. You're gonna have some providers that tell your patient that they're experiencing vertigo, and when you talk to them, you're like, I think you're just lightheaded. I don't think you're experiencing vertigo. But you don't say that, but you're working through that process. So here's a whole host of different types of symptoms. And I posted this for you because I wanted to share it with you and give you an idea of the type of information that I'll start to include relative to the way we talk about dizziness in class. Vertigo in particular is often used to describe everything relative to dizziness. I have vertigo. In actuality, vertigo is the sensation of self-motion when no self-motion is occurring. It is the perception that you have a distortion of self during otherwise normal head movements. Your body is in motion mentally while your body is still. You are in motion and your body is still. It's a distorted perception. It can turn internally, where it is happening within this false spinning sensation within yourself, or externally, where the room is moving around you. And it doesn't have to be spinning. It also includes false spinning sensations and other false sensations like swaying, tilting, bobbing, bouncing, or sliding. So you'll encounter a subset of patients that are experiencing something known as bedaide debarkment syndrome. This is a very difficult population to treat. Hold on, it's French. Bedaide debarkment. Bedaide debarkment syndrome is the perception of internal bodily motion when we are still. Typically, bedaide debarkment syndrome is triggered after travel or earthquakes. Welcome to Southern California, okay? In this, if a patient has experienced a very turbulent flight, if they have experienced extended period of time where they are exposed to persistent motion, when they get off of that activity, they still feel like their body is in motion. You may have experienced this at some point in your life, where perhaps you get off a boat and you still feel a little bounce. Usually it goes away. For some, it does not. And in this, patients typically experience a relief from their symptoms when they return to the activity that triggered their symptoms. So they do not have symptoms when they're riding in the car, they do not have symptoms when they're flying, they do not have symptoms when they're on a boat. In order to counteract this, they often rock back and forth to make it go away. Yes?
Is there an incidence rate of diagnosis of that following like larger earthquakes? Like I'm thinking of the Japan 2011 one.
I don't know if it's necessarily well documented within the literature, but it's something to consider. I would say sometimes it's a traumatic event that triggers it, like an earthquake, and then sometimes it's very innocuous. I've had a handful of patients who have perhaps slept on a dock on vacation, like out in the water, and they can't shake the perception. Weeks or months later, they still feel like they're moving on a dock when they're still. So they'll lay in bed and they're like, I'm right back on the dock. I'm right back on the cruise. I can't get it to stop.
Is that, does this happen in people who may have already had some symptoms and now it's been exacerbated, or can it just happen to whoever?
I would say that it happens usually pretty organically, in the sense that patients will typically not have a history of vestibular concern, and then this will be triggered. And the thought process behind it is challenging, because how do you get it to stop? Typically their vestibular system is working the way that it should. It's a mismatch or some type of alignment between the visual, vestibular, and somatosensory system that has gotten off track. And as a result, this person is going to feel when they're still in motion. And so they often are entered in therapy where they're looking at complex visual stimuli in order to downweight the internal perception of self-motion. It can be very, very challenging.
So we won't see abnormal results then with that?
Typically, results are within normal limits. And you, depending on your work setting, you may see patients with bedaide debarkment for the first time, where it is the first presentation that they've ever had, or it is not uncommon that you see patients where you are maybe the 7th or 8th provider that they're visiting with, and they've had V&Gs done before, and they've had vestibular testing done before, but now they're visiting with a new physician because this might be the place that kills them. So it is a complex condition at the end of the day. Malday department. Bad, literally bad deboarding.
That's what I was gonna say.
Yeah,
That's
it's
what it
just,
sounds like.
we did not get off. Very bad, okay? I'm gonna give you guys your 5-minute break here, just so we can touch base. Sound good? Can I answer your question?
Yes.
Yes.
I was like, I took my.
Now you have it.
I'm like